by Dr. Indu B. Narayanan. She is the consultant oculoplastic surgeon at Comrest Eye Hospital.
So, I'll be talking about an atypical case of cellulitis. This is how it turned out. So, beyond cellulitis, unmasking the masquerade. So, this lady, she was a 71-year-old lady with history of bronchial asthma and diabetes and hypertension. She was being treated as case of orbital cellulitis twice, which was 6 months apart. So she was admitted and was given IV antibiotics. And then this is how she presented to us. She presented with drooping of the right upper eyelid of a duration of 4 months. So she was asking what can be done. Again and again, this is recurring, and what is wrong with this? So on examination, there was complete ptosis with thickening at the infralateral orbital rim, and also there was induration, mild induration in the supromedial quadrant. And also there was restriction in the elevation. So we went ahead with an imaging, and MRI was taken, and you can see that there is bulky and hyperinter superior rectus and levator palpebrae superior complex, which was tendon involving. And also you can see the surrounding fat stranding. So what next? Obviously, an incision biopsy was taken from the most superficial which was available from the infralateral rim, and this was the histopathology report. There was multiple non-caseating epithelioid cell granulomata involving the skeletal muscle. And also you can see the multinucleated giant cells. So the diagnosis, it is not orbital cellulitis, but a case of sarcoidosis. So then she was evaluated by a pulmonologist as well as a rheumatologist. All her blood parameters, including serum ACE levels and calcium, was normal. MAN2 was negative. CT chest was normal. And during the time of evaluation, she had painless, non-tender subcutaneous nodules developed in the forearm, and a biopsy from which was also taken, and that was again confirmative of sarcoidosis. So she was started on oral steroids along with methotrexate, and this was her at 1 month of starting the drugs, and this was 2 months of starting the drugs, and she has been maintained on methotrexate now. So the discussion part is that not all cases of edema, proptosis will go into the diagnosis of orbital cellulitis. All these are the mimickers of orbital cellulitis: inflammatory, idiopathic orbital inflammatory disease, IgG4, sarcoidosis, thyroid eye disease, even lymphoproliferative lesions. All this can mimic orbital cellulitis. So if at all any atypical feature is there, like a recurrence, a chronicity, or a poor antibiotic response, or anything which is atypical in the imaging, you need to go in for an additional workup or a biopsy. A short discussion on the orbital sarcoidosis. This usually majority presents in the lacrimal gland, which is about 55% of the cases, and also as an orbital mass in 20%, and the lesser is the optic nerve involvement on the extraocular muscle involvement. So the 85% of the majority cases presents as well-defined lesion, but and like in our case, it might be around 10 to 15 cases it occurs as an infiltrative one. And it is not necessary that there will be concurrent systemic involvement. It's only just 50%, 35 to 50% cases. And systemic involvement might occur in around 8% of the cases in the coming 5 years. And please note, serum ACE, calcium, and lysosome levels may be normal. So, what the take-home message is that biopsy remains a gold standard in all non-resolving orbital inflammation, and early recognition of such cases is required, and so that we can avoid the misuse of antibiotics, as well as the right treatment can be given. Steroids and the immunomodulators are the treatment in such cases. And also, systemic evaluation is a must, and it requires a multidisciplinary approach, and discussion with the pulmonologist and rheumatologist. Thank you.
Thank you, Dr. Indu. We are open for